Good morning, everyone. My name is Rosie, and I am one of the directors of Conquerors Care's Tiny Wellness Initiative. Today, we are here to talk about maternal and fetal health. According to the March of Dimes, Michigan's maternal mortality rate in 2003 was 59.4 deaths per 100,000 births. This rate more than doubled from 2018 when it was 23.2 per 100,000 live births. In the U.S., more than 700 women die from pregnancy-related complications each year, and in Michigan, around 25 of those deaths are preventable. The leading cause of pregnancy-related death includes sepsis, infections, hemorrhaging, and also preeclampsia. Black women in Michigan die from pregnancy-related complications almost 3 times the rate of white women. And Hispanic women in Michigan die at a rate of 2.5 times more than white women. This is why we at Conquerors Church would like to educate our mothers as much as possible on the importance of maternal health to reduce these very difficult and astonishing maternal mortality rates. So I'm here today with a few of our panelists that are here to discuss the importance of maternal health. We will also be, each one of us, discussing some of our testimonies regarding maternal health and how important it is that if you are pregnant to seek prenatal care as soon as possible. So I will have each one of our panelists introduce themselves at this time, and then we will go into testimonials, and then we will also open up the floor for questions.
Hi, everybody. Thank you for coming. I'm so glad that you all came out for this event. My name's Joanne Garrissey, and here within the church walls, they just refer to me as Sister J. From a clinical lens and paradigm, I started off my career as an LPN. After that, I got my NAPNES. Wasn't done yet. Decided I wanted the ADN, went and got the RN. Finished the NCLEX through that. I went into work in administration where I needed a BAS and a BSN both. So I went and got those two. Still wasn't done. Went and got the MSN and the AAPRN and the CNP, and then just for good measures, I went and got an MDiv as well.
Good morning, everyone. My name is Leonda Hicks. I am also a co-director of the Tiny Wellness Initiative through Conquerors Cares. I am a mother, and I am one who thought that I wanted to study, I studied biology, and I thought because of Bill Cosby on The Cosby Show that I wanted to be a OBGYN. However, once I got to the hospital and did internships, I just did not like it. And so I am an administrator now, and I am really excited about this discussion because of my own health issues with carrying my son.
Good morning, everyone. My name is Kenyatta Herndon, and I am a certified nurse midwife as well as a board-certified lactation consultant. I began my education with a bachelor's of psychology, and then I received my bachelor's of science in nursing. Afterwards, I returned back to school after working 5 years as an emergency nurse to receive my master's of science in nurse midwifery. And right now, I'm currently pursuing my doctorate of nursing practice. Thank you.
Well, wonderful. So we have a pretty diverse panel up here, and we are just excited. I can begin with my testimony, if you all don't mind. I went to a routine doctor's appointment during my pregnancy. I was 1 month prior to my scheduled birth date, and my doctor was giving me an exam, and she said, did your water break? And I'm like, what do you mean, did my water break? She said, well, your amniotic fluid is low. I'm gonna have to induce your pregnancy. And I said, well, what does that mean? You mean I'm getting ready to have the baby today? And she said, yes, you need to go straight to the hospital. So I called my mom, I called my husband, and we went to the hospital. And I just wanna encourage everyone to make sure you take your prenatal care, and it's very important, because had I not gone to that doctor's appointment that day that was scheduled, I don't know if my son would be here today. I ended up going into labor because they induced me on a Friday, and I gave birth to him on a Saturday evening at about actually 11:23 that evening. I had signed up when I got to the hospital to be a part of a study because black women, as they told me, had shown patterns of low amniotic fluid. So I said, if my story can help someone, I'll go ahead and do it. And during that time, there was a team of doctors that would come into my in my room constantly, around the clock, constantly checking me. And I couldn't get any rest. They wouldn't let me eat. All I could have was ice chips. I love ice chips from the hospital, but I was hungry. And during that time, as I said, I had finally got some rest. I was in a sleep, and all of a sudden, I felt a doctor examining me. And I woke up, and I was mortified that a doctor was examining me without even giving me any warning. So as women, we have to advocate for ourselves. Needless to say, I was someone who had private insurance, so I didn't feel like I should have to be treated as someone who was just a number or a statistic. No one should be treated that way, so it's very important to advocate for yourself. I did demand that that doctor never came back in my room again, and I told them that I will not tolerate that. But there's so many women, and you can probably speak to this, that don't advocate for themselves because they don't know their rights or they don't feel like they have a voice. And so I ended up, throughout my pregnancy, I had one doctor. My doctor had a team of doctors. It was, I was at Physicians for Women at the time, and it was 3 doctors. And so my actual doctor did not deliver me. She was not on call that weekend. But it turns out that the same team of doctors who was doing the research study, they wanted to go ahead and deliver my son. And I said, well, is my son in distress? Is there anything going on? And they said, no, we just think you've been in labor too long. And I said, well, no, I want to call my doctor. And she said, don't do anything until I get here. And I said, I will wait for you. And so I think it's very important to know your rights. Know that you have a voice, and know that if you do not advocate for yourself, it could be detrimental to not only yourself, but your baby. Amen. Okay?
To expound on what Leonda said, she was discussing advocacy. Advocacy goes hand in hand with prevention. And most of you all out here know an ounce of prevention is worth a pound of cure. And I'm going to preach and preach hard to you on prevention and getting in front of the complications. Leonda didn't even know what amniotic fluid was, much less if hers was low and much less if she leaked. She wouldn't know. A lot of our women don't know. Speaking to you simply from the lens of, yes, I have a clinical background, and yes, I have a million certificates and initials behind my name, but looking at this from an absolutely custom perspective of the lens of the mom. I come from 3 generations of gestational diabetes. My mother was 20 when she was pregnant with a set of twins with gestational diabetes in the 60s. She wasn't overweight, not in any stretch of the imagination, and she seroconverted and became a full-blown insulin-dependent diabetic. Along comes me, 25, 26 years later, larger than her. However, that's a risk factor, but not a given. Gestational diabetes, gave birth to 2 children, seroconverted, insulin-dependent diabetic. 25 years after that, my daughter comes along. A few more pounds than I might have had, and again, a risk factor, where the bigger risk factor is the familial background and history. So at 28, 29 years old, she pops up with gestational diabetes. My one and only grandchild is almost 6 months old. No, he's just over 6 months old now. And he was born at 38 weeks. So close enough to full term to be called full term, but not your 40. He was, we nicknamed him a sumo wrestler or a busted can of biscuits. I mean to tell you, this boy had rolls on him like the Michelin man that's on the side of the road. His father's only 5'2". His mother's only 5'5". So height or length is going to be standard or less. And he came in at 11.5 pounds. I believe he was 21 inches. I'm not positive, but you can only imagine what that looks like. Okay, so again, we've got genital urinary complications. We've got at least 3 diagnoses with kidney issues. We knew ahead of time there was a heart defect and a hole that's got to be watched and monitored. Diabetes isn't just a word. Diabetes comes with complications. Just using this one child as an example. He's got 2, possibly 3 genital urinary complications, and his next surgery is scheduled for next month already. He was born with a heart defect. Fingers crossed, doing well. The cardiologist is monitoring constantly. We have not gone forward with heart surgery yet, and the hope is that it's closing on its own. Any baby who is going to be born to a gestationally diabetic mom, you've got to understand he was in his mom's in utero in the tummy, literally bathing in her glucose for darn near 9 months. Absolutely accustomed to a nice high level of sugar buzz. This baby gets born and the sugar buzz is gone all of a sudden. Look who's in the NICU for 11 days on IV antibiotics, trying to learn to self-regulate his own sugar, which is a vicious cycle. Your sugar goes up, your insulin kicks in, baby's glucose levels go down. You have to get fed. You get fed, your sugar goes up. Your insulin levels peak. You are going to tank back down again. This is a non-stop cycle, which then impacts this baby. You're doing heel sticks or finger sticks or blood draws in some way every 1 to 2 to 4 to 6 hours to get this poor child to stabilize. Then you're running a glucose 5% solution or a glucose 10% bolus. Then you're pumping him full of glucose. Now you got to give him an insulin. It is a nonstop, every 6-hour, repetitive cycle in the NICU, in an incubator, under the lights, while mom is just heartbroken and can't get to him and can't fix it. So when Leonda said to advocate, we mean it. And we mean it screaming from the rafters, we mean it. Show up to these prenatal appointments, get in front of it, get a specialist on board. The word diabetes is a word that is thrown around loosely in our vernacular. It is a commonplace occurrence. It is sky high among the Black community, more than any other community that there is. And these babies need the support, they need the help, they need the advocacy, and they need the prevention. Again, an ounce of prevention is worth a pound of cure. If you're obese before you get pregnant, get this off so you're not impacting the glucose levels of your baby. If you don't have enough folic acid or enough vitamin B, start taking it before you get pregnant. Everybody here, I think, would agree, unrelated but similarly, we all know shingles is a miserably painful illness and disease. Would you rather prevent it or would you rather treat it? Same with the gestational diabetes. You would much rather prevent it than you would treat it.
And to go along with the conversation of advocacy, can everyone hear me okay? Okay. So to go along with that, I agree 100% with both ladies, how important it is to have self-advocacy. But just to kind of help out in the discussion, what I looked at as a midwife from my own experience working in healthcare now 11 years, as well as with my own situations as a patient, is for Black women, especially as we're speaking of Black maternal mortality, what does the advocacy look like? You know, walking in a Black body in itself can be a sense of intimidation and threatening. And therefore, when we step into doctors' offices, we are perceived very different. So for myself, as well as for my clients that I serve, in my community that I serve, one of the things I questioned was, well, what does advocacy look like? How can we advocate for ourselves? Because that means so much to so many different people. So I actually looked and got some help. I looked online as well as for my own research. So I was inspired by one author named Farah Yusri, and I'm using my phone for my notes. So as well as the Henry Ford Health System, they also put out a piece working on patient advocacy and how, as Black women, we can advocate for ourselves. The first thing I wanted to point out is it is not our responsibility to have to take care of our health, but it also is our responsibility to take care of our health. When I go through these points, I'm not saying them in a sense of saying that we by ourselves are completely responsible for what happens to us, because as Ms. Leandra said earlier, even in her own personal testimony, that you don't know everything. You did not receive a medical degree. You work in a different place, as well as we are not always perceived as we should be. And so therefore, some of the things that I noticed when it came to self-advocacy is just understanding the rules of engagement. And as a provider, it is my job to not only understand the rules of our culture, but also I would like to educate all of us on how we can engage when it comes to medical professionals, because there is a type of way we're trained. There is a type of way the hospital system works. And unfortunately, among our community as Black Americans, there is not a lot of understanding of how that system works. And I know when I was growing up, we used to call it code switching. So I'm hoping that some of these tips will give you some code switching kind of tips and rules. They're not all encompassing, they're not an ultimatum, but just some things to think about, okay? And then the panelists, if you guys have anything you want to add to it when I go through these, I think it would be a really nice conversation piece. All right, so the first one was, as Ms. J talked about, is knowing your health history. It is so important that if you go into a doctor's appointment, if you need to write down a note to make sure you have a list of all the medications you currently take and all the medical diagnoses you've had, from if you've ever been diagnosed with a medical disorder such as like diabetes, or if you've ever had a surgery such as having your appendix taken out. That is so important when it comes to prenatal care as well as care for anyone. And this isn't just for Black American women, this is for anyone who walks into a hospital setting. You should know your history and you should know what supplements you're taking. So if you're taking a medication such as aspirin, all the way to if you're taking a supplement like CoQ10, you should know. You should know, and it is important for us to know. If you just decided to start taking a weight loss supplement, that is still considered a medication or a foreign substance in your body, and it is important for us as healthcare workers to know, because drugs do have interactions in the body. If we want to give you a prescription, as well as certain symptoms can be a side effect of something you're taking. So that will help us be able to diagnose specifically what ailment you are suffering from and be able to help you wisely. The next one is, please come prepared with a list of questions. I hate to say it, we supposed to be able to relate to everyone, but the way that it works in the medical health system is most of the time, prenatal appointment, I have 20 minutes. I have 20 minutes to get to know you in the 30 years of life you've lived. So it is really helpful for me as a provider if you come with your questions written down. So even if we don't have enough time in this appointment, I'm always more than happy to talk to you about it in the next appointment. Or I can write your question down and send you an email or through your patient portal that we can answer those questions. It also helps us just stay on topic. And then, as we talked about before, sometimes you can have a little bit of like pregnancy brain, or you can forget, or sometimes it's just something that comes up that you don't remember. So it's really helpful for yourself as well as for us if you come with the list of questions. The next tip is bring someone with you to an appointment. As Black American women, we are usually the caretakers for everyone else. However, in these situations, it is so important that you have a support system to help care for you. One thing is, it is hard as the person being treated to listen to everything that the provider tells you. But if you have a support person, and that can be whoever, a husband, a mother, a sister, a friend, it's very important that you have someone who's there with you. That also can help give you some confidence. Sometimes speaking on very challenging conversations, you need a little confidence. So having a loved one there who's there to advocate and support you as well is very, very helpful. The next tip is to enroll in some type of group prenatal care. A lot of the hospitals have all types of group support programs, and we need a community around us. It is very important as Black Americans for us to work in community, and it is a deep-seated foundation of our culture. So when you see those flyers and hear about those handouts, it is important for you to sign up. Those are ways that you can connect with other people who may be having the same concerns or questions as you. And now after COVID, a lot of things are online, so you can actually join in a more virtual setting. Most importantly, I think, Ms. J, you spoke to that, was like speaking up and speaking up for yourself. But what does that look like? Right now, we're in the environment of the Real Housewives of Atlanta and the Bad Girls Club. And as a Black American woman, especially if you particularly are of darker complexion, if you come in and you decide to speak up, there's stereotypes that you're working against. You're working against the stereotype of someone feeling like you're a mad Black woman, someone perceiving your nonverbal cues of your body language as being dismissive, intimidating, threatening. So what does speaking up actually look like? Well, some of the things that I have found helpful as a patient as well as a provider is, first of all, being self-aware of how you feel. In that particular circumstance, it is okay to be angry. However, as Christians, we know to be angry but sin not. So therefore, we have to use the Spirit of the Lord to help us temper that anger and use it in a constructive way. So a good example that I thought to be able to use was, like, for example, if you are speaking to a provider and you feel like they're not hearing or understanding me, one of the things that you could ask is, you could say to them in this statement, I'm not feeling like my questions are being answered. Can we pause here just for a moment? I have 5 questions and I would like to get through them all. So just taking a second to acknowledge, like, I acknowledge what you're sharing with me, but I don't think you're understanding what I'm saying. That is a very nice way to say, I don't think you're listening to me. Yes, and with that, that also is a way that a provider can take a second and stop, because sometimes we get caught into our task. I need to get your blood pressure. I need to get to the next room. I'm running behind. My lunch break is being cut off, but when you just say, please, can you just stop for a second because I don't think you're understanding me? That can be perceived a lot better than you getting angry, storming off. Or unfortunately, what we do a lot of times, despite the stereotype that Black women are so aggressive and intimidating, most of the time we actually, with the research, that we do not advocate for ourselves. If anything, we get angry and just accept it. I hate to say it, but we have a lot of struggle-love relationships with our providers where it's like, I don't like this doctor, they don't listen to me, but oh well, I just keep going. And that is an absolute no, which goes into the next point of, if you feel like this physician or this nurse practitioner or this provider is not meeting your needs, you have every right to find a new one. Thankfully, here in Michigan, as well as throughout the U.S., we do not live in a medical desert. There are hospitals and clinics everywhere. And despite if you have private insurance or Medicare, they all pay, and you can go and pay someone else to provide yourself with better service. And then the last big one that I wanted to highlight was use technology. Many of us we don't even have a sign-in for our patient portal log, which will give you information about what was done in the appointment, what labs were collected, and what were your care instructions for going home. That is very important, as well as do not settle with mediocre care. Do not accept someone's opinion that you do not agree with. It is okay to tell us as providers, I don't agree with this treatment plan, or this treatment plan doesn't work for me. You're asking me to take a medication that I cannot afford. You're asking me to come to appointments that I do not have transportation to get to. That is so important. I don't know how many times that I've had patients where I've seen them after 4 weeks and I'm like, you have gestational diabetes. Can I see your sugar log? And they tell me, I never even picked up my AccuCheck. I've never picked up my glucose monitor. I didn't get my materials. And I'm like, well, it would have been nice if you would have told me this a while ago, because I could have advocated for you. Hospitals have social workers. We have grants. We have support to make sure we provide you with resources. So I just want to empower you as Black American women, as advocates for your community, because we are the pillars of our community when it comes to advocacy and caregiving, that there are resources that you can take, as well as you are allowed to speak up, but there are ways you can do it where it can be received. Okay.
And I will piggyback, can you hear me? I will piggyback off of that. Just from my personal experience, I went from a pregnancy where I had no prenatal care to some pregnancies where I did have prenatal care, so I want you guys to understand it is important. I come from a culture that is very, doctors are usually the bad guys. We rely on homeopathic things, we rely on, prayer, we rely on other things, and we feel like doctors are the bad guys. Doctors don't listen to us. So when I became pregnant, my first pregnancy, I was 20 years old. I had just finished with this ordeal because I had endometriosis when I was a teenager, went through about 8 surgeries in 2 years. So needless to say, I did not like doctors. It took them a while to diagnose my illness. So when I became pregnant, I was like, I don't need to see a doctor. What do I need to see a doctor for? That was a big mistake because at 32 weeks, I had really high blood pressure, preeclampsia, and my son was born at 32 weeks when he could have gone full term had I gone to prenatal care. Needless to say, I learned my lesson. So after that, I got pregnant again, and I started seeing a doctor. I found a doctor that I felt comfortable with, that I felt like I can ask questions and I wasn't going to feel intimidated. It took me a few tries. I did find 3 different gynecologists before I found the one that I felt was the right one. And my daughter, who was born, my second daughter, she was born at 39 weeks, very healthy. And then my third pregnancy, my other daughter was born at 40 weeks. Had to be induced because, she's the lazy one. She did not want to come out, so she had to be induced. But those were good, healthy pregnancies because I made the choice to have prenatal care. So I think it's really important that we have prenatal care, that we go to doctors, that we ask questions, we speak up and advocate for ourselves, even if we feel intimidated, because at the end of the day, it's our life on the line and it's our child's life on the line. So please, please make sure that you are asking these questions, that you are speaking up. And I know it's hard because sometimes you go in the doctor's office and you feel so intimidated, you're like, I don't know what to ask. I'm not sure. But do research, come in with a notepad and questions and ask these questions. And even if you sometimes forget, use that patient portal. I do it all the time, even now. I'll, email a question on there that I forgot to ask in the appointment, and they'll respond. So use those resources that are available to you. And that is why this is so important for all of us here today, to help you understand that prenatal health is very important. We don't want you to have to go through the things that we went through. We want you to be prepared. We want you to be equipped. And that is why Tiny Wellness is all about. We will have those support groups for you. We will have, help you connect with prenatal care. We will help you if you need maternity clothes, if you need a crib, whatever you need to make sure that your pregnancy and your child's first year is off to a great start. We are here for you. So now we'll open the floor for questions.
So real quick, we've talked a lot about having the right physician, the right healthcare team. What is it that we should be looking for in a healthcare team, that provider? What would be your advice?
So I will start speaking on just the fact of me being a nurse midwife. A lot of people do not know the difference between my career and what we hear as lay terms of midwifery. So the first thing you want to be aware of is board certification. So here in the state of Michigan, health providers now must be board certified. So traditionally, a midwife would just be considered any woman or who would actually attend to births. So if you were attending to a multiple number of births, or you yourself had about 10 children, you could consider yourself a lay midwife. However, I believe it was 2012, we had some legislature that went forward saying that we need to protect our general public by making it a little clearer for us to know who is who when it comes to licensing. So by 2017, we as a state agreed that if you are to call yourself a midwife, a nurse, a physician, any type of health provider, you need a license. So therefore, in midwifery, there are lay midwives who have no training, not to say that they have no experience, but they have no training when it comes to traditional formal medical training. And then the next level is professional midwives who are board certified. These are the midwives you see mostly doing home births. And there is a particular clientele who can go to their births and attend their births, which would be a woman who is relatively young, low risk factors, no significant medical history. And then you have me, which is a master's prepared nurse practitioner, where I have to have a bachelor's and a master's degree in nursing, and also carry 2 licensing, one for as a registered nurse, as well as my second one is a specialty nurse practitioner. So that would be how you determine the difference between a nurse midwife versus a professional midwife and a lay midwife. And then the same thing when it comes to a OB-GYN provider, that's obstetrics gynecology provider. They are a double board MD or DO, because MD is traditional medical doctor, DO is a doctor of osteopathic medicine, and so that is the difference between them. The obstetrics version is the area that takes care of pregnancy and maternal health, and the gynecology is for women's health. That means all the women ailments outside of pregnancy. And so OB-GYNs in our country are board certified of both. You also can see a family medicine doctor who has birth privileges. That's normally like a primary care doctor who has a specialty degree where they get a certification to actually attend healthy, normal births, which is almost synonymous with what I do outside of not having a medical degree license. So board certification. Also, we have ACOG, the American College of Obstetrics and Gynecology, that you can go on to find a physician. And for prenatal care, as well as for midwifery, we have AMCB, which is American Midwifery College boards, where you can find board-certified nurse midwives and professional midwives. Mm-hmm.
All right, and then to jump off of what she told you, all of what she said is accurate. And again, putting it in a practical sense, most people who are pregnant, who go to see a doctor are insured in some way. You've got commercial insurance through your work, through your husband's work. You've got Medicare. You've got Medicaid. You can go and find out through, and I'll pick on Aetna, Cigna, United. You go on their portals, and you simply plug in the information. I want to give birth at St. John Moros in Detroit. I want to give birth at Troy Beaumont. Okay, so here is my insurance, and here is the hospital of my choosing. I want to filter down by all of the board-certified OBGYNs with birth practicing privileges who are on site and accept my insurance at the facility of my choosing. Narrow your list down and use your resources. You own this insurance, whether you've got a copay or a deductible or a co-insurance, it's coming out of your wallet. You have the right to choose how you use your benefits. You will then come up with a list of, and I don't care if it's 2 or 22 or 222. You're then going to filter that list down by criteria that is important to you, of your choosings. One person might want to go under a language search where I need my practitioner to speak Spanish. Another person might want to go down a search of office hours because they work Monday through Friday from 9 to 6, and they need somebody with office hours on a Saturday. They're just going to narrow your list down. It's your insurance. It's your money. It's your copay. It's your deductible. Use this to the best benefit you can and make your wise choice. You're then going to get a list and start calling them. Hi, are you accepting new patients? Hi, do you have availability Saturday at 2 p.m. to see me? Hi, do you have the ability to do fetal heart tone monitoring and tocolysis in your office setting? Or are you going to send me to the hospital every time we blink an eye and something goes wrong on a weekly basis? Do you have restrictions on your table weights? And yes, some providers do. There's equipment that is only applicable to certain weight patients or certain circumference patients. They simply can't put the belts around a circumference, and they're going to send you to the hospital on a weekly basis. Well, maybe if I know this up front, I might make a different choice. I might go to a larger office. I might go to a group practice. I might need somebody who speaks Arabic because my first language is Arabic or Spanish or something else. Yes, we need board certified. Yes, we need training. Yes, we need experience and background, but we also need this to work for our mommies. If mommy can't communicate with the provider due to a language barrier, all of his certificates in the world ain't going to help her. If mommy can't get to an appointment because she doesn't drive and she needs somebody after hours to drive her, he can be the nicest guy in the world and speak Spanish and have a wonderful bedside manner. And if she can't get to him, it ain't gonna help her one bit. We need this to work for our mommies.
And just to add to that, when we're looking for providers, I know right now we've been having like a cultural shift where everyone's looking for, especially among the Black community, a Black provider. Unfortunately, right now among healthcare providers, Black American providers make up less than 2% of all certified licensed health providers in the United States. But then also, if we want to speak more closely to what does the Black community encompass, we're not a monolith. So Nigerian American provider is not the same as a Black American provider who is someone who's a descendant of slaves here in the American states. So we have a completely different culture. So as a result, when we're looking for providers, especially right now when we're dealing with this high maternal mortality rate, we feel like the easiest way to solve the systemic racism and structural racism we're dealing with our medical unit is to find somebody who look like us. Well, that's not reasonable for everyone. So when you're looking for the provider, and as Ms. J was saying, when you're having these initial appointments, it is more important to have that conversation of, okay, I am a Black American woman. These are the high rates. You as a provider, what are you and your practice doing to help advocate for my concerns? And they allow the healthcare provider to tell you, and you will either feel comfortable with what their statement is, or you will know right off in the first 5 minutes of them speaking that they're not concerned. If they say I take care of everybody the same, that may not be a provider you want to deal with because they're not aware that I need you to take care of me differently. And if you're not aware of that, that may not be helpful. So even if you do not have a provider who looks like you, there are providers who are not Black American who would be able to provide you. And also, me, myself, have dealt with Black American providers who, like I said, they may be an immigrant or they may come from a different economic status as me, and they did not serve me well. So it's okay that even if they are Black appearing, if they're not meeting your needs as a Black American woman, then they're not it either. But there are providers who will meet your needs in those first couple of questions, and it is okay for you to say for yourself, I need specialized care. Are you prepared to provide me that care? And make sure that they're able to provide you. And if they can't, it's okay. You can find care somewhere else.
So we've talked a lot about what mothers need, but you can't have a baby alone. Fathers, what would you say is the father's role in prenatal care? How do they advocate?
Well, in my practice, I absolutely love to see the fathers. And one of the main reasons in research they say how fathers can advocate is, first of all, being present, as we talked about, having that support person. So just having that male presence in the room says that this woman is cared for, this woman should be treated with respect, and there is a place of protection for her. The next thing fathers can do is, when you're at the prenatal appointments, be aware. I don't know how many times I've seen fathers on their phones or just not listening. Some of it could just be that they're tired from working, but some of it is they feel like I'm not allowed to be in this space. However, you are allowed to be in that space, and it is important that you're not only there presently, but mentally and emotionally there, as well as please bring your questions, please bring your concerns. When I'm on the labor side of things and we're in labor, it's nothing like when I have a lady who is trying to do a labor without any kind of pain anesthesia. And I could tell her all day that she's great. I could tell her all day that she can do it. It is nothing like when her male partner comes and says to her, baby, you're so strong. You got this. One more contraction. It's like they just find superhuman strength and they get through. So your words, your presence, your touch, doing counter massage, all those things matter. And then after baby, there's good research that shows that fathers who are present, changing diapers, giving support, those women are more likely to breastfeed for longer, recover faster, and deal with lower levels of postpartum depression. So having that male presence there is completely important and foundational to maternal care. So if you are present, know that you are welcome to be in that space, you are needed in a space, and you are heard.
I don't have a whole lot to add to that because she covered most all of it. I do. we need those daddies to support the mom in the way that mom wants. What is her love language? Some women want to be touched. They want to be massaged. They want to be stroked. Some women don't want you getting anywhere near them. Daddies need to know what mommy's love language really is. Maybe she wants a gift of service. Okay, she's in labor and you're going to go get the ice chips. Yes, we know that the hospital staff could do that for her. But the fact that it's you anticipating her needs and you are doing, not hearing, not seeing, not listening, not sitting in a corner, but doing for her. That's her love language. That's what she wants. That is what is going to give her the ability to keep on keeping on and to get through this. Some women want the accolades and the attention. Some don't, and you will be her protection. There are women who want 14 people in their delivery room, and there's women who want to throw everybody out except the physician, and nobody is going to be in there. You are the stand in the gap. You speak for her, you advocate for her when she simply can't. Pregnancy brain is a truism. I don't care whether we believe in it or not. And labor is just pregnancy on steroids intensified. She can't think for herself. She can't speak for herself. She is busy producing a human being. You need to stand there. You need to be her gap, be her protector, be the provider, and provide what she needs.
And there's sometimes where dads see things that the moms don't see. I used to be an interpreter at a health center, and I remember one situation where I was interpreting for a family, and the husband said, well, she swells a lot. And she kind of just threw it to, it's a normal pregnancy thing, right? And he was like, no, this seems different. I see her, swelling more than I think she should. And so it was, I informed the provider, and it was something where she was having really high blood pressure. And so had he not spoken up, because she just threw it to, it's a normal pregnancy thing, right? Had he not spoken up, I think the situation would have been different. So sometimes you guys will see things that the mom doesn't see, because, sometimes when we're pregnant, we feel like everything that is happening to our body is just a normal part of pregnancy. But there are times when it's not. So you guys are that extra set of eyes, that extra person to see that something is happening that should not be happening, and you can advocate and speak up.
Rosie, it's a good lead in to postpartum is just as important as prenatal care, because there's a lot of times after you give birth, the nurses and doctors just kind of forget about you. And being mindful of your body and what may feel different, again, like she said, is very important, because there are a lot of women who may give birth, they could have a blood clot, or something can go wrong, and giving birth, you can really literally die from giving birth. And so can you speak to that, about how important it is to really know what signs to look for after you give birth, that postpartum? I remember not wanting to leave the hospital because I was scared. Like, oh my God, what am I going to do with this baby? Because when you're in the hospital, they're 24-hour care. And my son had to be in the neonatal intensive care, so I didn't have him in the room with me. And so from the time I got released, they give you maybe a 20-minute, it felt like, class about how to change diapers, introducing you to formula, different things like that. And it was just a lot, even down to my son had jaundice. And I'm like, oh my God, I didn't think about what pediatrician I was going to go to. So these are things that no one talks about. At least I didn't think to ask these questions. Thankfully, while my son was in NICU, I met his pediatrician, and she was literally a godsend, and he ended up having to go see her the day we were released, the next day after we were released from the hospital. She made room for him in her schedule. But can you talk about that whole postpartum period, about what you should look for in your body, kind of what's normal, and you can also speak to your professionalism as a lactation counselor. Thank you.
So this is such a complex question. However, I'm going to try to break it down just to make sure in the simplest forms that everyone is able to follow me and understand. So first, I'm going to just speak on like routine vaginal delivery. Either a second degree tear or just a very smaller tear, like how do you take care of yourself? So usually we'll send you home about at 48 hours post-delivery. So after you have your baby, we'll send you home about 48 hours later. The things that you're looking for is overall, C-section or vaginal delivery, you should feel overall well. You may feel sore, you might feel tired, but if you start feeling as if you have any symptoms of like the flu, like you have an upper respiratory infection, you just feel overall like I just generally don't feel well, that is something that should be brought to the attention of your provider. Then the next things I'm thinking of is when it comes to taking care of your body. For a lot of ladies, they don't know that during the postpartum period, your uterus is cleansing itself from the pregnancy. Your uterine lining is still shedding. So you will have what we call lochia bleeding. It looks very similar to a menstrual cycle, but what is important is it is the way for your uterus to reset and prepare itself for a future pregnancy. So bleeding that is normal should be bleeding that is less than when 1 hour filling a feminine pad. So if you have like a normal regular size feminine pad, you should not be filling that pad in greater than an hour. And that bleeding will transform itself from bright red, which is called rubra, to a darker colored red, to a brown, to a white. If you ever notice within that time that your bleeding goes from that white substance back to red, that is a sign that you might be having a hemorrhage. And so therefore, it is important for you to take care of your body to notice the bleeding that you're having. Now, I also tell mothers if you're up working too hard, you will have more heavier bleeding, and that is another sign for you to rest. So in a normal vaginal delivery, you should be aware of your bleeding. You should be aware of your overall feeling of wellness. And you should not have any kind of symptoms that seem as if you have a common cold, the flu, or any kind of ailment. Next, you should not have headaches. If you are having a headache and you take Tylenol or take a nap and you wake back up with the headache still present, that is a danger sign of preeclampsia and you should be evaluated. Likewise with your blood pressure. Your blood pressure should be stabilizing. You should not have headaches. There should not be changes to your vision. You should not feel as if you're dizzy and you're not able to sit up and care for your baby. If you are feeling any of those things, that is something that is really important for your health provider to be aware of. All the way to the point of if you have a headache that is not resolving with Tylenol, you should be calling your health provider and driving to your hospital. So those are very important symptoms that people may feel like are just normal, but they're not. If you have a cesarean delivery, then you want to be aware of your incision site. So that area should be clean. It should be dry. We should have surgical dressings on it, and you should not have anything seeping through your surgical dressings. The only care you need is you would just allow soapy water to run over that site when you take a shower. Otherwise, you should not be dousing yourself in the bathtub. You should not be scrubbing that area. That area should not have an odor. It should not have any kind of purulent or a drainage that has a different color, and therefore you should be overall well. With the cesarean delivery, you should be following up within 2 weeks of your delivery to do a wound check and to make sure that your skin is healing. Your skin should resemble, like we call it, like a zipper. It should all be nice and well approximated together. If it is opening up, that is a problem, and you should be making someone aware of it. When it comes to postpartum mood, we are all familiar with the term baby blues. That represents like the first couple of days after having a baby, you may feel a little emotional. You're so happy to see your beautiful baby. You may be overwhelmed with the feelings of now becoming a mother. You may be overwhelmed. You may be overwhelmed. However, you should not feel like you cannot get up and take care of yourself. You should not feel as if you have no energy. You should not feel as if that you are unable to care for your baby. Postpartum depression is usually diagnosed at the 2-week mark because your body is going through a major hormone shift when it comes to your emotions after having a baby, and that can be some of the emotional lability where you're going kind of up and down emotional roller coaster. However, if you feel any thoughts of harming yourself, harming others, or an intense feeling of sadness that you cannot past, that is something that you should be bringing to the attention of your healthcare provider. And if you have a history of depression or anxiety, then you should be actually seeing your provider via Zoom or in person at 2 weeks, vaginal or cesarean delivery, for the sake of a mood check to make sure that you are coping well, because we know that people with the previous history of depression or anxiety are more likely to suffer from postpartum depression or postpartum psychosis, which is an even more extreme version of depression. My next concern would be when it comes to breastfeeding or bottle feeding. If you choose to bottle feed, which I hope that you would at least attempt to try to breastfeed, but if you're in a situation where you already have tried it with the previous pregnancy, or you are just not motivated at this time for various reasons and you are choosing to bottle feed, then to take care of your breast and your breast health, you want to put on a well-fitting bra and give yourself support so that your milk can naturally dry up. Try not to add a lot of stimulation to your breast, as well as no breast massages. Try not to have like the water and different things like hit your breast to make you have more breast milk, because you do not want to call for more breast milk because you're choosing to bottle feed. If you are breastfeeding, we as lactation consultants believe in breastfeeding on demand. We call the postpartum, the first 6 weeks, as the 4th trimester. It is normal for a breastfed baby to be fed every hour to hour and a half. They are connected to you. They've been connected to you for 10 months. This is their 4th trimester. They need their mothers, and it is important to have the breast available to them as they need. Breast milk is not only just food for them, it's water as well as comfort. And just like us, we need water sometimes to drink. Sometimes the baby needs to nurse just to drink, as well as to feel emotional bond and attachment to their mother. Breast milk is medicine, is water, is food, is supplement, and it's emotional support for a newborn. So it is important that you take care of your breast, make sure you have appropriate latch, and make sure that your breast feels soft. You should not have a lot of pain. If you're breastfeeding, you're having intense, sharp pain that feels like pins and needles, that means you need to adjust your latch, or you might be dealing with an infection called mastitis. So we would like to know about it. And I'm like, did that cover everything?
I think you did.
Oh, I have one more.
Yes.
It is just a real it is a common occurrence that you're looking at some blood clots. There is the potential. If you chose to extend your leg, point your toe toward the ceiling, and the back of your calf just sent you into excruciating pain. It's something called the Homan sign, and you've likely got the beginnings of a blood clot. If that blood clot moves, you've then got something called an embolism, and we're dealing with a morbidity and mortality if this travels and moves to the lung. It is unfortunately something that happens after birth from some immobility. It's something to look out for. It's something to watch. It's something to monitor. If you can simply move your toe. And then looking at this again, I'll bring it back to the mommy practical lens. Again, I've spoken before on insurance. We're dealing with Medicare, Medicaid, commercial insurance, and advocacy. You've decided you want to breastfeed. Yay for you. I applaud that decision. That is the best decision. Did you know that every single insurance carrier, as part of Women's Health Act that was nationwide, will pay for you a breast pump at zero cost share whatsoever? And along with the breast pump is going to come all the breast milk storage bags. And you can get an electrical, you can get a bivalvular, you can get one that plugs in the wall, you can get one you wear. Every insurance company has their own vendor, and they reach out to you. In addition, you've got the Medicare, you've got the Medicaid, we've got all kinds of programs. All of these supplies can be gotten to you for free, but you've got to advocate and stand up for yourself. You need to let your providers in your facility know ahead of time, I'm going to breastfeed. You need to get online with your insurance provider and say, okay, I want a breast pump sent to me. Or you're going to tell your provider 3 months ahead of time, order me a breast pump. It needs to be available to you when you need it and not 2 weeks later. Again, back with the Homan sign, back with the potential for the blood clot. There are specific stockings that are compression grade, that are medical grade. Yes, we know everybody in the world can go on Amazon and buy these. And these are over the counter. They're not prescription grade. They're not prescription strength. You got a pain in your calf, or you're immobile, or you're on bed rest, or you're in some way not moving around, You simply tell the provider, I need compression stockings. They are more than happy to order these for you. You run them through your insurance. They're covered as part of the Women's Health Act. And you get these, most of the time, mail order delivered to your front door without you having to leave the comfort of your couch. I want you to advocate for yourself. I want you to use your benefits. I want you to know what resources you have available to you. Here in southeastern Michigan, particularly in Macomb County, we have formula banks. Let's just pretend mommy can't breastfeed, doesn't want to breastfeed, didn't succeed at breastfeeding. Mommy now has to use formula. I know members of our own congregation here who have gone through this. A standard can of Enfamil Reguline is $49.99 all over town everywhere. Your baby's going to go through, I don't care, 4 or 5 cans every 2-week pay cycle. You run that by a month, you're looking at $500 a month in baby formula. We have resources available to our mommies who enroll in our program, who meet criteria, who meet guidelines, and their formula can be provided to them at no charge. Macomb County, in addition to having food pantries, also have baby pantries where you register and they literally give you 5 cans of formula of your choosing that you need a month with 0 cost share to you whatsoever. So whether you're going to breastfeed or whether you're going to formula feed, there are tons of resources out there to support these decisions if the moms know that they have the rights to advocate for themselves and to ask and to use.
May I add one more thing? Also, here in Michigan, we have breast milk banks. So I believe right now the closest hospital that gives breast milk, this breast milk is sterilized. It's also goes through the preservation process where they screen it for all bloodborne illnesses and disease. But University of Michigan has a breast milk donor. You need a prescription from your pediatrician, but if you cannot produce your own breast milk or you're having issues with delayed breast milk production because of diabetes or high blood pressure in pregnancy, you can actually get a prescription from a pediatrician to get breast donor milk. And there's also a national breast milk bank that is here in the U.S. that you can receive products from online, and they will ship them to you in a refrigerated container and cart.
So I think at this point, we're going to open it up to the audience for questions, if you have any questions.
All right. Someone from the audience would like to know, what are the leading causes of infant mortality in our region, and what initiatives are being undertaken to address them?
So the first main cause of infant mortality is lack of prenatal care during the prenatal stage and therefore prematurity. So for Black babies, infant mortality, premature birth is one of the #1 reasons for them to be lose their life. So we have to be very cognizant of making sure we receive prenatal care, that we can carry our babies to term, which is 37 weeks, or even longer to full term, which is 40 weeks or greater. The next would be SID, sudden infant death syndrome. And unfortunately, one of the causes of that is smoking in the house, as well as there's a lot of unknown causes. But the main one we see is a mother who smokes cigarettes or marijuana. Those babies are more likely to pass away.
And so in this state, there are different initiatives to help assist with those problems. For example, one of the programs that Tiny Wellness is providing with the assistance of the United Way at the Southeast Perinatal Coalition is safe sleep training. So we are going to provide our mommies with safe sleep training so that they understand what are the safe sleep practices. A lot of times in our communities, we think it's okay because we're breastfeeding to just have the baby co-sleep with us because it's easier, right? You just turn around and he's right there. But that is not safe for the baby, and that is one of the causes of SIDS, the co-sleeping, the having a blanket and a bumper and all these lovely things in a crib. That is not safe for the baby. So sometimes as mothers, we don't know that. So providing this training for you to understand what are the risk factors of SIDS, because SIDS is sudden infant death syndrome, so it's a death that is unexplainable, and all of these things are sort of risk factors for that happening. So that is one of the things that Tiny Wellness is offering. I know that Community First Health is a community clinic in Macomb County that also has a maternal and fetal infant health program that also provides those things. And then just also, we will be connecting you with providers. Whether you have Medicaid or don't qualify for Medicaid, we have resources so that you can get low-cost prenatal care.
In addition to what both ladies have also said, we can tell you everything to do. But if you don't have the resources or the means available to do them, it's not going to do you one bit of good. So, again, with the Tiny Wellness Initiative, we are here to support the mommies. We're here to support those babies through their first year of life. And once enrolled in the program and accepted, we know that safe sleep is one of the most important factors. Don't be in mommy's bed. Don't be in your cushy bassinet. Don't be in your rock and play. You need to be in your standard full-size crib with a crib sheet and a crib mattress, and Tiny Wellness will provide that to our engaged enrollees.
Okay, we have another question. What is gestational diabetes, and what are some signs to look for?
Okay, gestational diabetes is an elevated glucose or A1C, mostly glucose level, in a pregnant woman who has previously never been diagnosed with diabetes before. It is unfortunately one of the most common complications of pregnancy after preeclampsia. The mothers will develop a very high glucose level. It's diagnosed typically by a glucose tolerance test, and there can be several of these tests ordered. It is incumbent upon the mom to ask and advocate for herself with the provider when he comes across or she comes across and says, "We want to get a routine screening glucose tolerance test from you." Okay. A routine screening glucose tolerance test. Is that a 1 hour, a 3 hour, a 6 hour? Do I have to be fasting? Do you take this at Quest Lab off-site? Do I come to your office on-site? Are you sending me to a hospital to make me drink glucola and be fasting for the next 6 hours? There are many different ways and many different time frames that this test can be initially ordered and follow-up ordered. It's an unfortunate reality that a lot of our mommies who do get diagnosed with gestational diabetes later in life seroconvert to a type 1 or a type 2 insulin-dependent or oral medication diabetes as well. And again, the word diabetes is thrown around as if it's commonplace, and it's not. It creates a host of problems with the mom and with the baby. It does lead to morbidity and mortality. You can't have, I shouldn't say you can't have, you shouldn't be moving forward without intricate prenatal care. I personally had gestational diabetes. It's in the generation above me, it's in the generation below me. I had to go through a neonatologist and a pediatrician and an OB-GYN. I can't tell you that it's comfortable or it's easy. It is what you need that is best for the most healthiest outcome of the child. We may not always like what's the best. We need to do what is the best. We need to work with these providers. I can tell you that, okay, so I liked my OB-GYN. I did not like my perinatologist. We didn't continue our relationship. As soon as the birth was over, that relationship ended.
I'll speak to more in layman terms, what is gestational diabetes when it comes to your body. So pretty much in the Black community, diabetes has a stigma to it. A lot of people assume that it's just a disease that you get when you're 70 years old and you are older and you have overate. However, the stress of pregnancy in itself can cause your pancreas, which is the organ that produces insulin in your body, to not work as efficiently. So when you become pregnant, if you have a family history of diabetes, meaning especially a first degree relative such as your mother, grandmother, or father or grandfather, then you are more likely to suffer from diabetes in pregnancy. as well as if you are already overweight when you begin your pregnancy. So some of the things that we do as providers to help protect you, because a lot of patients feel like, well, is there something I've done wrong? It's not necessarily something you've done wrong, it's genetics. And one thing about pregnancy is it brings a level of stress to the body that it reveals, like I like to say, it reveals all secrets. So if you have some type of area in genetics that is a weakness, if you become pregnant, your body will show you that weakness, and that is usually what happens with gestational diabetes. So we as providers characterize it in different categories. We first start with diet control. So when you have your first glucose test, that is either, if you have a first degree relative, we do it at about 12 weeks of pregnancy because we want to catch you early. You are more likely to have gestational diabetes if you have that strong family history. So about 12 weeks to 14 weeks, we want to check you, and so we'll have you take either a 1-hour glucose test, a 2-hour glucose test, or a 3-hour glucose test. That is just dependent on who is your practitioner. All clinics do not have the same criteria, and different ones benefit from different criteria. The difference is, really quick, is the 1-hour and the 3-hour are a little more patient-friendly, and the 2-hour is diagnostic. So if you have a patient who doesn't have good transportation, you might do the 2-hour because right at the end of that test, they will have a diagnosis, versus if you do the 1-hour, it may be easier on mama, but she has to come back for a 3-hour if that 1 hour is abnormal. So back to at that point, if you are to receive a positive gestational diabetes diagnosis, the first thing we try to do is control it with diet. So like I said, your pancreas is not working as efficiently, and so diet changes can actually take some of that stress load off your pancreas. And we'll watch you for a couple of weeks to see if diet improves your insulin resistance or retention in your body. If it does not, then you want to look at either oral medicine like metformin, or you might need insulin, which is an injection, and it will depend on what your blood sugar levels are looking like. And so that's pretty much the gist of it. If you are diet controlled, you can see a provider such as me, a nurse midwife, because I am an expert when it comes to lower risk pregnancies. However, if you are insulin requiring, you may have to see a perinatologist or maternal fetal medicine, which is a high risk OB doctor, or just an obstetrician, gynecologist, a regular OB-GYN doc.
And we need to be mindful, mommy's growing a baby in there, and that baby is growing every single week. And if mommy's on medication, that may be changing every 2 weeks. And if mommy is on metformin, she might be on 500, and then we might be on 1,000. Then we could be adding some Lantus or some long-term, mid-term insulin to this. Then we're gonna be changing this insulin dose every week or two based on mommy's blood glucose readings that she is going to be carefully monitoring at home. And again, we're going back to the practicality of this. You're going to put your insulin and your metformin or your, I don't know anybody on Januvia, but if you were, you're going to run it through your insurance, who is then going to kick it back and say, well, we already dispensed your insurance for this month, and we gave you a month's worth of Lantus, and you're on, I don't care, 55 units a day. Well, guess what? My blood sugar's through the roof, and my providers just ordered me 62 units in the morning and 55 at night, and I darn near now need to double my insulin. You all need to be dispensing me some more, and there is going to have to be some conversations. Yes, you're entitled. Yes, it's paid for. Yes, it's part of your benefit, and yes, you need to advocate for yourself. Just because you had a prescription 2 weeks ago doesn't mean it's accurate in this next 2-week time frame.
And it's really important that you actually do take that diagnosis seriously, because even if you're just diet controlled diabetic in your pregnancy, if you do not manage it while you're pregnant, the research shows that you are more likely to develop type 2 diabetes after the pregnancy. And therefore, even in a postpartum period, at your 6-week appointment, when you come back and return to your provider, we will screen you for diabetes again. So it's very important that you do take care of yourself, because it's not so much of just having a larger baby or I can't eat the food I want to eat. The thing is, you do not want to be a young mother who now has to live the rest of her life with diabetes. Diabetes does destroy blood vessels. It does destroy organs, function, as well as organ tissue. And if you have have high levels of sugar in your blood, that is not a good thing. So just to be aware that if it is not addressed in pregnancy, you will deal with it later in life. And we're seeing younger and younger women in their 20s and 30s who are now insulin dependent for the rest of their lives because they didn't take care of diabetes during a pregnancy. So it is not something to just ignore.
Another question?
How does socio-economic status impact infant mortality? What are some strategies to combat that?
I think that it definitely has an enormous impact because a lot of times when you come from a lower socioeconomic status, education goes right along with that. So you probably are not, I come from a family that has a low socioeconomic status, and most of my family didn't go past 5th grade. So they are not equipped to advocate for themselves and to, read correctly and to figure out how can I find this doctor, not internet savvy, not able to, utilize some resources that may be out there. But when you have a low socioeconomic status, even though those resources are there, you're not sure how to access those resources. You're not sure where to find that information. So that is why we start these types of programs to be able to bridge that gap. So we target those families that come from those socioeconomic backgrounds so that you know that there's someone here to help you. We are the kind of the middleman between you and finding the care. We will help you do that research. We will assist you with finding the right doctor, finding the right resources. We have relationship with different organizations in the community where if you need something that you may not think is important, we would be the one to help you find it without you feeling like, I don't know where to go. So I think that is really important, and that is why the state has implemented these type of programs to sort of bridge that gap.
I want to speak to Black American women. And when it comes to socioeconomic status with us, when it comes to maternal mortality, it does not have any weight on our high mortality rate. So the Center for Disease Control and Prevention, which is the CDC here in America, states that even African American women with college degrees as well as higher socioeconomics, we are still 5.2 times more likely to die in pregnancy than any other group of women here in America. And I actually want to read some statistics to you. So for 2011 to 2015, Black mothers who are 25 years of age or younger were 3.3 times higher than white women to die in childbirth. That is 42 women per 100,000, whereas for white women, the number is 13 women per 100,000. And this doesn't, this is no difference in how much money you make. It's no difference in how much education you've had. It makes no difference in what neighborhood you live in. If you're a Black American woman in America and you are pregnant, you are 3 to 5 times more likely to die than your neighbor who is white, Hispanic, Asian, or Native American. And next after us would be Native American or Alaskan Natives. And so because of that, we've done a lot of research because we're trying to understand why Black mothers are dying. And the reason is because of structural racism, implicit bias, which means an unconscious racism among our health communities, as well as we have a whole system that is not targeting our community. And then there is some new research coming out on the stress of racism in pregnancy that is allowing our women to die. Just to name some of the big headlines that we have of Black American women who've died in our country in the last few months. We have Shamoni Gibson. She died of a PE in New York. Amber Rose Isaac. She died of HELP syndrome. Denise Williams. Asia Washington. And right now in Ohio, we had Brittany Watts, who was acquitted from being charged with having a miscarriage at home in Ohio. And we also have Jessica Ross, who's into late 2023, her baby ended up dying from decapitation under medical care. So among us, those are big headlines that were national news in the last 6 months about Black women of different economic status, education, and support who have died under medical care who've gone to all prenatal appointments and health care. There's also new research for 2023 and 2024 that shows that Black American women going to prenatal appointments does not guarantee that they're going to have longevity in comparison to their white counterparts. So this is a serious issue among our medical communities. We are having actual lobbying groups such as AIM, which is focusing on infant and mortality here in America, and also ACOG, which is looking at why our social determinants of health are not helping us live longer. And the main thing is that we need to understand implicit bias, the structural racism, and as healthcare providers, how we are not supporting our Black American population.
We have a question.
That is an amazing question. Thank you for it. And first of all, as a medical provider, I want to apologize to you that that was the way you were treated, because actually in my own clinic, we do not have to send women to the hospital to have their non-stress test because of their weight. I believe that was a individual issue at the providers that you went to. So the first way you can advocate for yourself, which may be hard because I'm not sure what city or community you live in, is to find a clinic where they can actually provide you with care in an outpatient setting, because it is a stigma to have to go into the hospital. It is humiliating and it is embarrassing because it puts you on Front Street because of something that you can't control. And now among the medical community, we have finally learned that obesity is not due to personal factors. It is a genetic component, and obesity is a disease that we need to treat with respect and care for all of our patients. So I am sorry that you had that experience, because that was very unfortunate, and we do not have to treat women that way. But when it comes to advocating for yourself, the first thing would be being aware of that obesity is a risk factor. And I feel like when you approach it in that way of letting the provider know, I understand that this is a risk factor. However, right now, this is where I'm at and living in my body. How can you best help me to manage my obesity as well as my pregnancy? And say, can we collaborate? We have a shared goal. I want to be healthy. I want my baby to be healthy. Please discuss with me what is needed so that I can be a part of the goal of reaching healthiness for myself and my body, as well as letting the providers know. It may be really tough, to tell the provider that you feel like you're being targeted because of your weight. But just as similar as if you feel like you're being targeted because of your race or your ethnicity, it is important for you to speak up, because sometimes providers are not aware of their bias. And implicit bias is an unconscious bias. And so therefore, they may not be aware. And if you bring it to their attention, hopefully it will help them see that they're not being compassionate in that situation. But if they continue to show a lack of respect, it is okay for you to find someone who is able to care for anybody.
In looking at that exact situation, I'm almost thinking that it was a misstep or a misspeak on the provider's behalf. It is not that provider had to send you to the hospital because of your body habitus. That provider didn't have the equipment in the office necessary to treat you. Certain tables truly do have a weight restriction, a weight limit of 300. Without knowing anybody's weight, a pregnant mommy could be well over 300 and not be able to be fitted on a table. It's potential that there are lengths of the monitors that go around the uterus, that go around the belly. And maybe you're needing something, and I'm just gonna wing it and say, you need something that's 70 inches around, where the maximum capacity that they have in their office is 55 inches around. Therefore, you need to go to another setting to receive this. This would be part of that advocacy search that we were talking about in the very beginning of this. Do you have the equipment in your office capable of treating me as a unique individual? And if the answer is yes, then wonderful. We're going to go through our criteria, and you checked off 2 boxes. And if the answer is no, then I may need to be looking elsewhere for a provider who does have the appropriate equipment in their office available to treat me as a patient.
Yes. I have a question. I hope you all can hear me. But I'm 62, and I had 3 different pregnancies, 3 different ways. I had a C-section. I mean, I had a birth where I had a spinal tap with my first child, and then the next one I had a C-section, and then my third one I came out as a VBAC. And I just wanted to know sometimes, because knowing that that you all have the monitor, the fetal monitor, the maternal fetal monitor. I don't know, is it because we know too much now that it's going on? Because back in the daytime, all I do, this is what my provider said. I didn't do anything different. I didn't ask him any question, anything. I just did what he suggested. Because now to the people that we know too much now, that's why we having these problems.
May I understand your question a little clearer? Are you asking did fetal heart monitoring have any way on the 3 different types of deliveries you had?
No, I think we're talking about the baby coming. You know how we've been saying about the baby, that we having problems back in the day, having babies now, how it's causing so many fetal death. Is it because we know too much now that we suggest that we can figure out our own health problems by looking up Google and all that sort of stuff, or is it because like I say, back in the day, I went to my doctor. We didn't have all this modern technology thing. So therefore, whatever my doctor said, I tried to do the best I could. But we hadn't heard as much death coming up as I'm saying now. That we're hearing it now, like so many kids, so many fetal death is happening. Is it because we get too educated and we feel that we know better than who went to school?
I think the issues have always been around. I think that there's more focus now that technology has improved and providers are able to sort of prevent these issues. The issues have always been there. Historically, there's always been mothers that die at birth. There's always been preterm birth. However, the focus has never been on it because probably we were not sure what the cause was. And now that we understand the cause, now that we understand the prevention, so now we're focusing it. It's always been there, but the studies were probably not out. People were not talking. People were not speaking up and saying, this happened to me. A family member speaking out and saying, my wife or my daughter passed away giving birth. Now that it's out there, now we are able to prevent. But I think that the complications, those problems have always been there.
And I want to speak to medical abuse. In this culture right now, I want to speak to the aspect of like families and patients Googling now and feeling like they cannot trust the word of their providers. Unfortunately, due to the pandemic that we have experienced as well as medical abuse, a lot of families and patients are not feeling as if they can trust the medical providers to have their best interests at heart. And so therefore, I have now noticed that I'm having more of a tug of war with clients. Whereas before, doctors and nurses were considered people of respect and are more of a hierarchy or an authoritarian. Well, now I'm dealing with more of people saying like, I don't trust you and I can Google and I know just as much as you. And it's more of a response to abuse, more of a post-traumatic stress kind of response where we as the medical community have not done our due diligence in providing clear health care. There's been historically issues with making deals with pharmaceutical companies or not discussing just all kind of intimate details when it comes to the health of our communities that has caused more backlash and more stress among the community when it comes to trusting us. And so therefore it is of us and our onus to build back up that trust among patients, and that's why we want to do more of a collaborative care model, more of a goal-oriented model, and more patient-centered care model because of that.
Awesome. Well, we would like to thank everyone, all of our panelists. I think some very great information has been shared, and many of you have heard us say that we are here representing the Tiny Wellness Initiative, and we would like for you to sign up and be a part of this. And how do you do that? You can sign up today, those of you who are here present with us. We appreciate you, but those of you who are watching online, you're welcome to call us at 586-372-6045. Again, 586-372-6045, and we can get you signed up. The goal is to do a pre-screening to see exactly what your needs are and to make sure that we're giving you the care that you need. It is not a one-size-fits-all. We do want to provide care as you need it, specifically for your needs. And we would like for you to spread the word because there are funds available to be of support for you throughout your pregnancy and post-pregnancy. So we hope that you will share this information with people. We hope that you have enjoyed this discussion and that something was said today that has enlightened you. We will again like to thank our panelists for their expertise, the testimonies that were shared. Sometimes we feel like we're alone, and we are not alone. We have all had experiences that have been good as well as those that have not been so good. But the more we share, the more we talk, the more that we communicate with one another, we can understand that we can share resources, share experiences, and you don't have to feel alone, and you can make it through to full term.
Thank y'all so much.
Thank you.